Hello, everyone. Welcome to Gina's NP Week celebration. I'm Jensine, the APRN Chair for Georgia Indian Nurses Association. We are excited to kick off our Nurse Practitioner Week with an interactive Q&A session with a very prominent leader from the Georgia NP community, Dr. Desire Clement. Our Vice President for GINA, Jenny Mathen, will tell you more about our distinguished guest and all of the work she has done for NPs in Georgia. Deepthi Varghese, President of GINA, will be co-hosting this session with me.
I have the pleasure of introducing our very first speaker, Desire Clement, DNP, APRN, CNM, FNP, BC, FA, CNM. She is an expert in women's health and health policy surrounding Georgia APRN scope of practice. She is a dual certified nurse midwife and family nurse practitioner, Navy veteran, and fellow of the American College of Nurse Midwives. She is the director of the FNP program and assistant professor at Emory University Nell Hodgson Woodruff School of Nursing. She continues to maintain a part-time clinical practice within primary care and women's health, serving the uninsured at the Clarkston Community Health Center. She also serves in the leadership roles as co-director of Georgia Coalition of APRNs and state director at large of United APRNs of Georgia, along with maintaining active membership in AANP, ACNM, NONPF, GNA, ANA, and STTI. Please welcome Dr. Desire Clements as she shares with us NP scope of practice.
Thank you, everyone. And thank you, Jenny, and thank you, Deepthi, and also Jensine. I'm honored to have this pleasure to come talk to Gina this week.
Thank you for being here. So the first question that we have is, what is the main difference between Georgia's scope of practice compared to other states?
Well, first off, unfortunately, Georgia is one of the most restrictive states to practice in for APRNs. And, that includes all four roles: the nurse practitioner, the certified nurse midwife, the clinical nurse specialist, and the CRNA, the nurse anesthetist. Unfortunately, we are one of 10 states left that is even required to still have a supervisory ratio. Currently, ours is 1 MD to 4 APRNs. If you're in an outpatient setting, it may look very different, though, if you're in an inpatient only NP specialty or APRN specialty, where you may be working under a different statute of the laws. Also, unfortunately, we are one of 4 states left without controlled to scheduled drugs to prescribe. It's unbelievable, but yes, we were one of the last in 2006 to even get prescriptive authority in the state of Georgia, and we still are yet to have be able to have the ability to prescribe anything but Schedule 3 through 5. And then finally, we're one of 2 states left that still cannot order disability placards when you have a person who is disabled and needs that placard and that authorization to take it to the Department of Motor Vehicles. It's not that we can't do it as much as in the statutes, it does not clearly spell out what is going on and doesn't, more importantly, recognize us to be one of the authorized providers along with PAs, like they do with physicians, podiatrists, and others that could be recognized on the list of approved providers to order disability placards. So with that, Georgia, and until especially, I just have to say, our big win last year, SB 321, we were the only state left that even had a restriction on advanced radiographic imaging. That is your CT scans, your MRIs, your nuke scans. We could only order them in case of an emergency. And within a certain amount of time, we had to notify the physician. And what that meant is especially when things like breast screening change, like for high-risk women, where we would need to occasionally order a routine MRI and other things along with a mammogram, it really has become a problem. And so it is something we needed to tackle because the other 49 states had no restriction on advanced imaging. So these are some of the reasons, unfortunately, Georgia remains in the red for what we call the green, yellow, red categories of full practice authority, reduced, and restricted, as A and P defines them.
Thank you, Dr. Clement. So you talked a little bit about restrictive practice in Georgia. Can you give us some insight into full practice and reduced practice in the United States?
Sure. So the difference with, we would be happy, I hate to say right now, even to do what we call baby steps to move us into the yellow range, which according to ANP, that is called a reduced practice state, where yes, the state practice and laws, licensure laws reduce the ability of NPs to engage, but it's in at least one element of NP practice. Whereas right now we remain in what they call the red category on the map, which is restricted practice, where not only do we have at least one element of NP practice that's restrictive, but we have what's called state laws that require career-long supervision, unfortunately, or delegation or some form of team management to where we always have to be working with a healthcare provider or supervised. So moving forward, our goal would be what we call go in the green. And that is according to the ANP map, where we would be in the company of the other 23 states and DC and several US territories. That is like the highest level we're trying to achieve with our practice, because that allows state practice and licensure laws to permit all NPs to evaluate patients, diagnose, order, treat, do all the things that we are already trained to the fullest extent of our education and training. But we do not have to be under physician supervision. We would be under the exclusive licensure authority from the Board of Nursing only, and therefore we could consult when we need to, because that is how we're trained. So with that, that is our eventual goal in Georgia. But with Georgia being, as I said a little bit earlier, the last state to have prescriptive authority in general in 2006, and then that split us into two different prescribing laws. That one are, most of our outpatient APRNs, which typically tend to be more the NPs, fall under, where you have to follow that nurse protocol agreement with the composite board of the Georgia Composite Medical Board, along with the Georgia Board of Nursing governing your practice. There's still our one small subset where we have a prescribing law that we just call everything in, or it's called a delegated medical act, that a lot of our acute care NPs and our CNMs, they still practice under, because then what happens is they can't do double duty, which means that, or double jeopardy, more importantly. You can't one day be prescribing under your own DEA with a filed nurse protocol agreement, and then the next day be writing under somebody else's DEA to order something like fentanyl or a stronger medication in the hospital. So unfortunately, that is what has split us. But where I'm going with that is, to back it up, is that what it means is it's still going to be baby steps in Georgia. You can't go from all of a sudden we're over here and now we want everything, because in this restrictive environment, and what we've also dealt with just with the imaging bill that took us almost 8 years to work on to get to where we're at, it's going to just take baby steps in Georgia. We have one of the most powerful lobbyist organizations with the Georgia Medical Association, and nothing against our colleagues at all. The bottom line is we just want to help remove barriers so we can help be a part of the solution to the workforce, and also this huge access to care deficit that is currently in our state.
Thank you. You mentioned SB 321 and removing that barrier for diagnostic imaging. That was a major breakthrough for us this year. And are there any current bills that we can help support at this time with legislation?
Well, I'm glad you asked, Jensine. Of course there are. We're going to keep working on your behalf. And I just want to clarify, I'm also with the work that I do is mainly in my role as the co-director of the Georgia Coalition of APRNs. When I'm out there advocating, it is not on behalf of my regular workplace. I just have to say that clearly. I work for a large urban university that you mentioned in my bio, but my views and my advocacy level and what I do in that volunteer role with Capron, or also in my role of being the outgoing, I'm getting ready to outgo on it. My second term as state director at large for United APRNs of Georgia, or UAPRN. These are the views and the work we do together as Capron. And so because of that, we do have a couple of bills that we're looking at. Georgia has what's called a 2-year cycle, legislative cycle. And so if something does not get moved forward in that first year when it's brought up, there's still a chance for in the second year of the legislative cycle between usually January to March to bring it back up again. And so that's where we're at. So last year we introduced something called HB 430, which is it was called an APRN omnibus bill, where we tried to tackle a few things. We tried to tackle we need to have a separate APRN license versus only an authorization to practice. We're one of only 10 states left that has that, where you can have I'm an NP, I'm a CNM, and an RN, and everything falls under one number, my RN number. So again, for the safety of the public and for tracking data, and also, in a crisis situation, we want to make sure we have a separate license number that matches our education and training level. Also, we have the ordering of the disability placards that we're going to talk about, that we're one of only 2 states left. We also had added that we tried to tackle going after getting home health services in alignment with some of the national initiatives. But part of that bill we had to strip back out because they did not want to hear about the home health ordering. So we're going to tackle that down the road, but we still have the other 2 left in there. And then there was another one where we were an initiative to try and mandate the workforce data collection on license renewal with the Board of Nursing. Again, that was another one that we've had to take back out. It was not approved to move forward, but these other 2 will be. There's also HB 369, which is language that was substituted into another bill called SB 92 that passed the House. This is a bill we partnered with the PAs on, where the PAs took lead on this bill, separate from the other one that we took lead on. And just to clarify, in HB 430, the only part that had the PAs tacked on with us is the ordering of the disability placards, because they obviously don't have the need for the separate license issue. But with getting back to HB 369, we tried to go for an emergency supply to start, baby steps, 5-day supply of controlled 2s in an emergency only for like someone over the weekend or an urgent care center, pain crisis. They backed it down to an agreement of a 3-day supply, but with 1 CEU every year of continuing ed in prescribing. And then also if you've been licensed for and have practiced for at least 2 years. So that was our ability to just try, and you can see where they already have brought that down. And so we're going to go with that. We've kind of come together and said 3 days is still better for the state of Georgia than no days. They are trying to talk us into hydrocodone syrup only. We're trying to still go back and say, no, we need something a little more than hydrocodone syrup. So that's where we're at for really the 2 main things we're working on this year.
Thanks. Now, you've been a certified nurse midwife for several years. What kind of pushed you to pursue your family nurse practitioner certificate?
Thank you, Deepthi. Well, I after delivering over 2,000 babies in my career, and I lost track, and I was getting a little older, and I was moving into my career in academia and teaching, which I loved after being a preceptor for many years. I made the decision that as I was going back for my DNP, I wanted to tack on another APRN while I was out, because I had always wanted to take care of the rest of the family versus only be focused just with women's health, gender-related care specifically. So that allowed me to add the FNP on, and now I'm able to still use both certifications. I just am now doing a little bit more primary care and outpatient gynecology is the plan, versus I'm not delivering at this time.
Do you mind briefly going over the scope of practice for various APRN specialties and roles? So like the FNP versus acute care NP and psych NP, nurse midwife, CRNA, all those different roles?
Sure. So what's starting to happen a little bit more as we've over time, our specialties have morphed, and we've more importantly, I think the complexity of the healthcare environment and the patients having more healthcare needs, and we have an access to care issue across the country, not just in Georgia, where we have a shortage of all kinds of healthcare providers. people are walking in more sick, more complex needs. And so because of that, we're starting to see a little bit more of a delineation push. For what I mean with that is a delineation of roles. So someone who is an F&P that is now moving more towards like strictly an outpatient focused role. It doesn't mean you can't go round in the hospital. It doesn't mean you can't, still work in like cardiology or other specialties or do other things than just primary care that's included in the F&P scope. But what it does mean is also it kind of looks at the acuity level of how you were trained with the acuity level of the population during your training. So with F&P, a huge focus is on primary care and the outpatient setting and prevention and promotion and yes, other specialties across the board, but there's really not training included for inpatient role. And now, according to our accreditation standards and NTF criteria and the different things that help to govern NP education, they're getting more specific. And out of that has come the emergency NP for strictly working in emergency and primary care together, because you have to be an F&P to be an ENP. There's also become the adult gero acute care or the pediatric acute care role, which now hospitals are requiring F&Ps to go back and make sure they have that training to run invasive monitoring and care for very sick patients in the inpatient setting. But what it is coming down to is more and more states, including Georgia, are looking at, they want to make sure that your specialty matches up with the workplace you're in, or at least that the population, your daily activities of who you're practicing and caring for is matching up with the acuity level of what you were trained at. And so again, I can't comfortably, as an F&P director now, and this is, I think, a big thing that's coming up with F&Ps, where before we could do it all, or we didn't have these other specialties. Now that we have these other specialties and people can more intensely work in these areas for care management, they're now wanting F&Ps to not be in those areas if they didn't have their initial training in that level of acuity to begin with.
Thank you, Dr. Clement.
Mm-hmm.
So I started my career as a nurse practitioner in cardiology and now do electrophysiology. I've had the pleasure of being in school at Mercer initially, where Dr. Clement was, she taught us health policy and women's health. And then I ran into her again at Emory University for my postmaster's acute care training. So I can completely understand the need for that additional certification when you're having to work in the inpatient setting as well.
Exactly.
So we have another question.
Sure.
You've been called upon multiple times to provide legislative testimony on behalf of nursing practice to the Georgia legislative. What was your experience like?
Well, I'm going to be honest, it can be a little daunting because you sometimes might be called up and sometimes with not much notice. Sometimes you get some notice with a bill that's going to be heard or introduced and they're like, hey, Dr. Clement, we want you to come up and give some expert testimony or speak to the bill and why it's important and what's going on and how it impacts nursing. Not always even APRN. I could be called for any parts of nursing. And so with that, when we have notice, it'll give us some time to prepare, just like you would for a presentation or a conference or something you were going to speak at. That's nice. But sometimes I've literally been caught up and they're like, we had a bill that's coming up now. We had to make an amendment or something's going on. And I got less than an hour warning. And I'm feverishly driving across Atlanta and trying to, get to the Capitol quickly. And sometimes it's just to come in and give, that expertise or their a position on it from the basis of how is this going to impact Georgia with nursing and statutes. So that's the daunting part I was talking about. It can be, the thing is that legislators, you're their constituents and they want to hear from you. And yes, they like to hear from the experts. Yes, they like to hear from everybody. And they want to hear that. But sometimes they may not always like what you're about to tell them. Sometimes they don't agree with what your position is. One thing that I find that's important is I really, in this in my advocacy role, I have to think of what's best for Georgia. It's not really about us loosening restrictions, removing barriers, all that just for our licenses to be another full practice authority state. Really, the true reason is to benefit Georgia and the people who live here. And we have some of the worst outcomes. We have such a severe shortage. We have women dying in childbirth. And so it's very important for us to all be in the sandbox working together collegially, to be able to remove restrictions so we can maybe take a mobile van down to a couple of counties where they have no doctor, or they only have one doctor and they're overburdened. So these are some of the reasons we're asking to help educate and come in and help teach you about what is our APRN role, what is an NP, how can they benefit, how can we bring and strengthen the healthcare workforce in a state like Georgia with over 10 million people and 159 counties, where only half of them, have a physician. So that is the hard part. So with this and with advocacy, I try to always remind myself, put my personal politics to the side. It's not about me when I'm doing this. It's about my voice and what I can bring as a nurse. And whether you can do it in my role or you can just only send an email when we send out a legislator call to action and say, please just send an email or go meet with your representative or your senator. That's okay too. We need to come together in nursing, keep a united front, a voice, and show what we can bring. And we can bring a lot and more than what people realize.
Well, thank you so much, Dr. Clement, for advocating for all nurse practitioners in Georgia and empowering us. We appreciate you and our audience spending your evening with us.
Thank you. It has been a true pleasure, and I wish everybody at GINA and out there a happy Nurse Practitioner Week.
Happy
Thank
Nurse
you for having me. Jensine, I don't think we can hear you. I'm sorry.
I'm so sorry.
It's okay. I had Jensine in school too, so it's been nice to see both of these previous students, now these beautiful nurse practitioners here.
Yeah, it's so awesome seeing you again. For those listening in, please join us all week as we meet 2 other NP leaders, give away fun raffle prizes in honor of our nurse practitioners. Please take a picture of yourself in your white coat and tag us on GINA Georgia on Facebook with the hashtag GINA Wears White.
Happy Nurse Practitioner Week.
Happy Nurse Practitioner Week.
Bye.
Bye.
Bye.